You're watching Cetome TV. Knowledge is power.
Since we've got a bit of time here, I thought maybe we'd cover a bit of triple positive.
Sounds good. I think that sounds really good. So triple positive, I've got the estrogen receptor, I've got the progesterone receptor, and the HER2 status.
Yes.
All of that,
yes.
Which should give me lots of options. Is this a good thing if I'm triple positive?
But once again, you have to go back to the biopsy and you have to look at the percentage of those receptors in each cell. So are you more estrogen positive? You know, do you have like 80% estrogen positivity and only 2% HER2? Do you have, 10% HER2 and 5% estrogen? What are the variables? What sort of subcategory do you fit in? And so obviously there's going to be many different subcategories of triple positive too. Right now, the way we treat triple positive, the standard treatment, when we first started, the standard treatment was to use a dual combination of HER2 drugs. And that was pertuzumab and Herceptin. And Herceptin was the original HER2 inhibitor. And we started doing that, and we found very early on that if you added a drug called fulvestrant, which is an estrogen inhibitor, if you added that too, there seems to be some sort of functional redundancy where estrogen is actually triggered in these patients. So
is this good? Not knowing functional redundancy.
Functional redundancy is not a positive thing for us because it means that the cancer has backup pathways to grow and divide. And so, when we first started using this combination of just targeting the HER2 component of it, we would eventually see, relapses fairly quickly. And so now what we know, and triple positive breast cancers tend to happen, from our experience anyways, tend to happen in younger women. And so they haven't reached menopause yet. And that's a big factor because their bodies are still producing estrogen. And you have to, with triple positive breast cancers, you really, depending on the amount of estrogen in there, you have to figure out, are you going to target the estrogen aspect of it or are you going to target the HER2 aspect of it? And one of the things that is most important in that is deciding, which part of that you're going to target more aggressively.
So that's why determining, is it 80% ER positive or just 50?
Yes.
Is it an important factor?
Yes.
But you could you not target at all? Could you not target?
Okay. That's how.
Okay.
That's the solution.
Not to give it away.
Yeah. So that's how we target it these days. So we have a few patients right now, and what we've done, and it hasn't been easy convincing the medical system to do this, but we've started with a combination of the two HER2 inhibitors. We've added an estrogen inhibitor. We've gone with estrogen suppression because the women in these cases are
40s.
In their 40s, 30s, a couple in their 30s. And we've had to suppress their estrogen. And that brings up a huge question. What do you do? Do you do estrogen ablation? In other words, do you permanently cut off the estrogen production? And so the person has to immediately go through menopause at an early age and then have a life of no estrogen? Or do you suppress it with heavy drugs? And what we found out is that not all estrogen suppressing drugs are equal. So, we're talking about the production. We're not talking aromatase inhibitors or fulvestrant, which is a estrogen receptor inhibitor.
Okay.
So, getting that original estrogen suppression is really important. And some of the drugs are better than others. So what we found is the more that you suppress the production of the estrogen in these premenopausal women, the more impact the HER2 therapies have on them. So right now we're going with strong estrogen suppression. We're going with 2 HER2 drugs. We're adding fulvestrant and maybe even an aromatase inhibitor.
Tell us about that, because we don't know.
So this aromatase inhibitor is a standard treatment, letrozole, exemestane. That's the standard way of treating estrogen-positive breast cancers.
I see. And so what you're doing is adding in a couple of these newer targeted therapies.
And adding that, yes.
Right. So in those cases of these 30-something women for whom this is a problem, once their treatment is done and their estrogen is no longer being suppressed, what does that mean in terms of cancer?
Well, it has to be constantly
recurrence?
suppressed.
Oh, like forever now.
Yeah, and that's why I was saying the importance is whether to consider ablation.
I see. Okay.
You know, actually ending the production of your estrogen permanently with an operation, it's called ablation, or just using drugs to inhibit it until you reach menopause.
I see.
So they both have their own, you know, unique side effects. And if it was me, I would probably go with ablation because estrogen is such a factor in triple positive breast cancers.
Right. So suppression
is probably, you know,
you just want to
you're still going to get some production of estrogen.
And what are the I mean, as a woman, I understand some of the answer to the question, but what are some of the downsides of cutting off estrogen development in my 30s or 40s?
There's a lot of side effects.
So it's not an easy decision,
it's like
obviously.
permanent menopause. You know, you're going through a lot of different things. Estrogen has many roles in the body, and it has many important functions. In fact, estrogen has two different receptors. There's what we call the estrogen alpha receptor and the estrogen beta receptor. And so the estrogen binds to both of them. Different tissues have different contents of either the alpha or the beta. For example, you have more beta in your reproductive organs and more alpha in your breast tissue. So when estrogen binds to the alpha receptor, it causes growth and proliferation of those cells that it's binding to. When it binds to the beta receptor, it actually does the opposite, and it stops the growth and proliferation. So it's like the gas and the brakes. The same molecule, just binding to two different receptors. So we really love the new drug fulvestrant. It's been around for a while. We were one of the first people to use it in Canada. And what fulvestrant does is it's replaced tamoxifen, and it specifically binds the estrogen receptor alpha. So the cancer causing the bad one. Whereas tamoxifen, for example, the original drug, binds both of them.
So if we have a drug that just takes care of the bad estrogen,
the cancer causing function of
then is it possible that women or men with this type of cancer could look forward to a time when a treatment is going to make it so they don't have to do ablation or something like that, and just the good estrogen is left? Am I not understanding?
Well, it works for a long time, but it's not perfect.
Okay.
And so you just increase your chances of survival with ablation and all these other things.
Right, at least for now.
Yeah.
We've just seen so much change in cancer treatment, so much evolution and great stuff in the 10 years. I'm just thinking, oh, well, at any point someone's going to come out with this, because they seem to be doing that with, in so many levels.
But this is one of the big problems with tamoxifen. I'm not sure if you remember, but tamoxifen, although it worked well for breast cancer, it had a lot of side effects, and it would also cause ovarian and reproductive cancers. That was one of the side effects of it. So women would take it, they'd get breast cancer, then years later they'd get a reproductive cancer, and that's because the reproductive organs typically have a higher percentage of the beta receptor than the alpha receptor, and tamoxifen would bind both of them. So it would shut off the brakes. It would shut off the gas, but it would also shut off the brakes. So it would affect different tissues.
I see.
We don't have that problem with fulvestrant.
Wonderful.
And so that's why fulvestrant is such a great tool for these triple positive breast cancers.
And again, once you know what the genetic mutations are that are driving your cancer, and you're on the proper targeted therapy, and assuming scans show that you're clear and you're now in remission, you can use liquid biopsy tests to make sure that there isn't any of that mutation showing up, or that it's not increasing in number, right? So that would be a way that people who don't necessarily, as much as you're advocating for it, want to have the ablation, could really keep tabs on whether those estrogen numbers are going up or no.
Well, there's another complication there. You can get mutations in the estrogen receptor gene, and what happens is you have to understand that it's a receptor. So the binding part of the gene or of the protein is on the outside of the cell.
Okay.
And so fulvestrant works by coming along and fitting into the alpha pocket and preventing estrogen from fitting in there.
Gotcha.
So basically it's like a steric inhibition. What can happen is you can get mutations in the actual gene, the estrogen receptor gene. And then what that means is it doesn't need anything to bind on the outside. It will self-signal.
Right.
So it doesn't matter what's on the outside, it's not going to be affected. The mutation is inside of the cell now, and it's causing it to permanently signal from the inside.
And can you use liquid biopsies to monitor that?
Yes, exactly. Yes,
okay.
yeah.
So
We have a liquid biopsy. It's an emerging mutation, and there's actually a drug that seems to be quite beneficial. Neratinib. It's a new drug. It's called a pan-HER inhibitor.
Okay.
So it inhibits a bunch of different epidermal growth factor receptors, like HER2.
Right. It really is.
And that's another thing we see. We see HER2 mutations in all breast cancers. So mostly in estrogen positive breast cancers, we'll see actual. So normally, if you're HER2 positive, you'll get more HER2 receptors on the outside of the cell, and you treat the patient with pertuzumab, or trastuzumab, or one of the newer drugs, TDM1. But in late stage estrogen positive breast cancers, we do actually see these HER2 mutations occur, and that's where all of a sudden HER2 is signaling by itself, without an interaction with the surface of the cell.
Interesting.
Yeah. So
and that too could be targeted.
That could be targeted. We can find that in
now. Once you know, it's just keeping an eye on it, isn't it?
Yes, it is.
Yeah.
Yes.
And CT scans are not sufficient to keep an eye on this stuff.
You have to do liquid biopsies, discovery-based liquid biopsy.
Thank you for watching Ketome TV. Subscribe below and stay informed.